about management part 1. Today we are going to learn about wound management part 2, that is on fungating wound, cancer wound. So you all are familiar with that. Uh, so let me share my screen. I hope my screen is visible to everyone.
Yes.
Okay, thank you. So before moving on to the next part, so I would like to know from you, what are the difference between bed sore and fungating wound? So last time we learned about pressure sore, causes, management, signs and symptoms, everything. You might have seen many cancer wounds in your career. So what are the difference you have seen? What is the major difference between this? Anybody, please unmute yourself and talk, or you can put your answers in the chat box. We all nurses. Please put your thoughts. Anybody? Please switch on your videos. I would like to see your faces.
Can you hear me?
Yes, yes.
Ma'am, this bed sore is due to continuous pressure. It happens, bed sore ulcers.
Okay.
Fungating ulcer is due to cancer cell.
Cancer cells. Okay, thank you. Any other answers? I have seen only 5 faces. Please switch on your videos. Okay. Put your thoughts. Pressure sore is loss of tissue or muscle. Cancer wound is progressive growth of cell. Okay. Thank you. Any other difference? Others, please respond. Okay, bed sore is mainly pressure induced. Okay. So thank you. Thank you for your answers.
Fungating wound is a growing wound.
Okay.
Yeah, bed sore is now is due to a pressure sore.
Okay.
But it is but fungating wound is very active and new tissues are coming up.
Okay. Thank you, ma'am. So the major difference between pressure ulcer and the cancer wound is the pressure sore. Most of the time we know how does it come. Okay, due to continuous pressure, unrelieved pressure. Okay, so the most of the time we can able to prevent the pressure sore formation and we can able to cure the pressure sore. Okay, but in case of fungating wound, cancer wound, we can't prevent and we can't cure. So that is the major difference. Pressure sore is preventable and curable, but the fungating wound or a cancer wound is not preventable and not curable. So these are the major difference. Other differences also there, because maybe the pressure sore because of the continuous pressure. The other thing is because of the cancer cells. So one important thing, this is preventable and curable, but that this wound is not curable. So coming to the definition, it is a primary or secondary malignant growth in skin which has ulcerated and difficult to heal. You can see this picture. So look like a cauliflower in shape. The term fungating refers to a malignant process involving both ulceration and proliferative growth. Okay, so the day by day that the proliferative growth will be there, and also the ulceration. There are lot of signs and symptoms will be there, and it look like a nodular fungus shape. That is why we call this kind of wounds like fungating wound, not because of fungal infection. It look like a nodular fungus shape or cauliflower in shape. So the important point is difficult to heal, not able to heal these kind of wounds. We can able to control the symptoms. So our aim is to improve the quality of life of the patient and family through symptom control. So there are a lot of symptoms. I'll come to that part later. Coming to the pathophysiology, we know what is cancer. Develop a non-tender skin nodules. When a nodules emerge, that nodules enlarge, that leads to disruption of capillaries and lymph vessels there. If there is disruption of capillaries and lymph vessels happen, what happen? Altered coagulation and disorganized circulation will be there. Finally, tissue hypoxia and necrosis. So this is how the fungating wound or a cancer wound develop. So this is the pathophysiology. So the next one is Marjolin ulcer. I don't know how many of you heard about Marjolin ulcer. What is that? Is there any idea? Any idea about Marjolin ulcer? Anybody? Okay, so Marjolin ulcer is a type of malignancy of the skin. Malignant changes in a chronic wound. Okay, for example, burn scar ulcer, pressure sore, or venous leg ulcer. So these are the type of chronic ulcers. So sometimes these kind of wounds, from these kind of wounds can develop fungating wound like cancer wound. So the pathophysiology is little bit different from that cancer wound. Appearance of mass in the wound. Okay, so not before present. You might be thinking like, okay, granulation tissues. But at the same time, the patients will be saying like onset of pain, not previously present. When you touch that part, the patient will be saying like, I'm having pain. Please don't touch that area. And followed by the change in character, volume, and appearance of drainage, that wound. So if you find these kind of changes in a chronic wound, better you can send the patient to the surgeon and take a biopsy. Okay, so make sure that whether there is any malignant cells. So this is a curative possibility cancer. So better you can send that prior to that. So if there is any changes there, we can able to cure that cancer. Coming to the problems. So there are physical problems, psychological problems, social problems, and spiritual problems. From the first day onwards, we were thinking about total care. Here also, this is a non-healing ulcer. this patient need a total care. So I would like to hear from you all. What are the physical problems the patients might have developed? Just imagine a the fungating wound or a cancer wound on the right buccal mucosa, right buccal mucosa. Okay, so what are problems that patients might have developed? You can unmute yourself and talk, or you can, yeah. Difficulty in swallowing, pain, very good.
Halitosis.
Yeah.
Bleeding gums.
Yes, bleeding, yeah, halitosis will be there. Then,
Bleeding gums.
yes, bleeding comes. Yes. Poor nutrition, the patient is not able to swallow properly, maybe due to that. Poor nutrition, malnutrition will be there. Discomfort definitely will be there. Yeah.
Poor oral hygiene.
Poor, yeah, they are not able to maintain their oral hygiene because of the huge ulcer. Okay. Nausea, maybe because of that smell, the patients might have developed nausea. And maggots, risk of maggots, skin changes. How does maggots come? How does maggots come?
When the cleanliness is not maintained of the wound.
Okay, poor hygiene. Any other
For
answers?
anytime this flies go and sit in that outside.
Okay. What happened when a housefly touched the wound?
They will lay the eggs over there.
Yeah, that is very, very important. Usually, the house flies are attracted with an infected wound. When they touch the wound, the house flies will lay the eggs. Within 8 to 12 hours, come out of maggots. So, very, very important instructions which you have given to the patient and family about the covering of the wound. They have to cover the wound properly, otherwise maggot formation is one of the major complications for these kind of wounds. So thank you. There are, let's see one by one, physical problems. As you already said, pain. Pain is one of the major problem because uh, you have learned about two different types of pain, nociceptive pain and neuropathic pain. These kind of patients might have developed two different types of pain because one is direct exposure of dermis. That time the patients will experience nociceptive pain. And the another one is the tumor will be compressing into to the nerves sometimes. That time the patients will experience neuropathic pain. So when you do the assessment, you have to do the proper assessment whether the patient is having neuropathic pain or nociceptive pain or both. So if you do the proper assessment, you can able to plan based on your assessment, and if your plan well, then the patients will get benefit. So the assessment is very, very important. Always you have to keep it in mind. SDPQRST. What is his site? What is his site? The site of pain. D is duration. How long the pain is, the patient is having pain. And then P is provocative factor or palliative factor. Q is quality of pain, what kind of pain, what type of pain. R is the pain is radiating from one place to another, radiation. S is severity. Severity means you can ask the patient uh, how much pain they have. You can use 0 to 10 scale, numerical pain rating scale. Okay, so then they can pain is a subjective that symptom. The patients can able to tell their that pain score, the severity. So you can use that scale, or you can use Wong Baker. If they are not able to talk, then you can use the Wong Baker faces scale. And
Facial expression.
yeah, and the next thing is temporal factors, whether they are able to sleep properly because of pain, whether they are able to eat properly, whether they are able to maintain their self-care without help. These all things come certain temporal factors. So these all you have to keep it in mind while doing the assessment of pain. And then the second point is malodor. Okay, so the two major causes for developing malodor is, one is stale exudate dressings have been placed more than days, because there no caregiver, no proper caregiver, the patient is not able to change the dressings. So that time they will keep the same dressings for number of days. So that maybe because of that, the patient, the malodor can develop. And the another important thing is because of the necrotic tissue. Okay, devitalized necrotic tissue in the wound. Because of that, the patients can develop malodor. That these kind of wounds can develop malodor. And the third thing is bleeding. Again, improper dressing techniques. Usually the dressings are adherents to the wound. Before removing the old dressings, we need to soak the wound with normal saline or plain water. If you soak well, we can able to remove the dressings from the wound very easily. Otherwise, if you don't soak that old dressings, when you try to remove the old dressings, maybe because of that small injury can happen, and that leads to bleeding will be there. And the another important thing is the tumor will protrude the major blood vessels. For example, head and neck cancers. So that time the tumor will be protrude the carotid arteries like that. So I have seen many patients like that. Because of one patient died because of bleeding, profuse bleeding. So we need to prepare the patient and family for that. And the exudate. Exudate means oozing out of purulent discharges or that pus from the wound. Sometimes that oozing out of liquid like watery discharge from the wound. So these kind of this we used to call exudate. And itching. Itching, the two causes. One is the leaking, the exudates will be touching the normal skin. That time the patients develop itching. And the another thing is emerging of new nodules, from the sides of the tumor. Maybe because of that time the chemical reaction will be there. That time the patients will develop itching. And infestation with maggots, we already discussed. If when the house flies touch the wound, they may lay eggs. Maybe because of that, the patients will develop maggots. And communication difficulties. So if they have communication difficulties, especially head and neck cancers, they are not able to communicate properly. If they are able to write down their problems, please give a sheet of paper and ask them to write down their problems, so that we can able to get all the details. So if they are not able to write down their problem, then you can see their facial expression. You can use non-verbal things, and based on that you can treat. Coming to the psychological part, altered body image. So that is one of the major issue. Okay, so here just imagine a pimple in your face. So that pimple is like little bit enlarged. If you have a chance to see a mirror, how many times you go there and see whether the size is enlarged or decreased, is there any mark happened? So these kind of anxiety will be there in our mind all the time. Just imagine a non-healing ulcer on their face. So this will be affecting the patient emotionally, socially, and spiritually. And sexuality. So maybe misconception of diseases will be there. This will be affecting their relationship. denial, sometimes positive denial there. So they will not, sometimes negative denial will be there. They will not accept their disease. They will argue. So if a person's come to you with a denial, so don't argue with them. So not take it as a challenge and convey the truth with the patient. So please the listen, and after a few weeks they will understand. The wound size will be increasing, the signs and symptoms will be developing more, these kind of that. After that they will understand. Okay, and fear will be there. What happened next? Depression, anxious, they will be anxious about their that wound, because what is happening next. So if you don't that give a proper attention in the anxiety stage, the patients might go to depression. So always try to listen their problems. Sometimes shame will be there, guilt will be there. So what we can do is you have to do a individual listening. Individual assessment is mandatory, because in front of the relatives they will not tell the truth. That you have to keep it in mind. In front of the relatives, caregiver, they will uh, try to tell the that they will hide the truth. So they will say like, okay, she is the caregiver, she will be doing everything for me, she is doing dressing, these kind of nice words will be tell you in front of the caregivers. If you do a individual assessment, then you can able to understand the real scenario. Coming to the social, the first one is family isolation. So family, sometimes if a person's developed this kind of illness, the family members can choose the corner side room and keep the patient there. So they will not allow the patients come out of the room, or they will not allow to come to the kitchen or dining area, anywhere. They will say like, you have to be there all the time, we will provide all the things there. So that will be affect the patient emotionally. And social isolation, society, the isolate the maybe before developing this kind of illness, there are many friends and relatives, neighbors that used to that travel together or come together and sit together and have tea, and these kind of occasions were there. But after that they will maybe they will not be come to this see this kind of patients. This will be affecting the patient emotionally, because of the maybe because of the misconception of disease and social stigma, fear of contagion, and also misconception. Again, they might be thinking like, okay, this kind of disease might spread to me also. That kind of that thinking will be there in their mind. And effects on family, effects on sexual relationship and marital disharmony, because nobody is willing to take the get marriage, these kind of people that married from a person from this kind of family. Why? Maybe because of the hereditary factors. So if a person, if the patient will hear this kind of story, definitely he or she will think and emotionally feel, because of me only my daughter is not getting married, because of my problem. Why God punished me like this? These kind of spiritual questions coming there. And then maybe because of my sin, God punish me like this. So these kind of spiritual questions will be there. What we can do is you have to listen. You have to listen, listen, listen. If you listen well, definitely they will try to explore their problems. Based on their problems, you can able to treat. Okay. Coming to the assessment, the one important thing is wound location. Is there any mobility import? We can able to cover the public view, or that is very, very important. I have a patient. He used to come with a large towel. He was having the right buccal mucosa cancer. So when he come to the OP, I used to ask him like, Uncle, why are you carrying this kind of big towel with you always? So then he told me like, I need this one, need to travel. So he used to travel by bus. So then he told me like, uh, you have to cut the edges of the that dressing things. So I said, I again asked him, why you are telling like this? I will cut everything. So then again I used to ask him. Then he told me like, yeah, after the dressing, he showed me like, so he took his big towel and covered that the wound with the big towel. So from the external, the public view are not able to find if there is any wound inside or not. So when he travel, if the wound is exposed, even after dressing also, the dressings are exposed, nobody is willing to sit near to him. If he do like this, like a cover with a big towel, nobody is know I have a cancer, I have a wound or not. So they are not seeing my wound, and they are ready to sit near to me. Just imagine. So this kind of coping mechanism is there. So and so that is where I'm highlighting this here is, we have to cover the edges from the public view. So that will be affecting the patients emotionally. If possible, they will be able to cover it properly, and from the public view, they will not be able to see what is inside. And wound appearance surrounding in skin, potential for complication. Again, head and neck cancers, um, the main complication is bleeding. The tumor will protrude the major blood vessels, so that bleeding will be there. And so that is very, very important in rural area patients. If there is a bleeding there, they will not be able to come to the hospital soon. So our duty to educate the patient family members, if there is accidentally bleeding happened, how they can manage in their home. So that all important. And the principles of management is palliation of symptoms. The palliation of symptom is controlling their symptoms. If they have pain, that try to reduce their pain. If they have a malodor or infection, try to reduce their infection or malodor. Managing exudates, if they have a exudate purulent discharge or oozing out of fluid from the wound, we can able to control the educate the patient and family about how to manage this kind of exudate, minimize bleeding. And holistic care. Holistic care is a total care. This kind of patient definitely need a total care, empowering patient and family in own care. So these are the principles of that management of own care. Criteria is to maintain or improve the quality of life through symptom control. So we know there are more many symptoms. So our aim is to that reduce their symptoms. Through that, we can able to improve the quality of life of the patient and their family. So here we need to provide an empathetic care. We know what is empathy, putting ourselves into their place. So that is empathy. We need an empathetic mind to treat these kind of patients. Provide a thorough bath before dressings, because these type of wounds are fragile. If you apply more pressure on that wound, it will start sometime that leads to bleeding begin. So better they can take bath. If they are able to take bath, you can encourage the patient to take bath, so that all necrotic tissues will fall down. Okay, after that you can clean with normal saline and put some medications. Ensure the patient had a dose of analgesics before dressings. That is very, very, very important. You have to make sure that the patient is pain free. Okay, if they have pain, You have to give some analgesics before that time. Then you can, after pain management, you have to do some, you have to do the dressing. Use normal saline for cleaning the wound. So we know there are a lot of necrotic tissues will be there. Lot of proliferation tissue will be there. So because of that, there are lot of necrotic tissue will be there. So that time malodor will be there. The cleaning is no other medication is needed for cleaning. You can use normal saline. You can teach the patient about homemade saline preparation. Select the dressings based on the type of the wound and the exudate of wound. Coming to the minimizing pain, if the patient is having deep pain, like aching, stabbing, continuous pain, these kind of pains are in the comes under nociceptive pain. So then you can use the WHO analgesic ladder. You already learned this. You can use WHO analgesic ladder. Okay, if the patient is having that tramadol, you have to just the second stage. The first step is paracetamol, NSAID, or adjuvant. Here you have to understand that if the patient is having nociceptive pain and neuropathic pain, then you can add some neuropathic management medication also. Okay, if that first step is not adequate, not giving adequate pain relief, then you can think about second step. That is tramadol, tapentadol. These all comes in second step. Again, you have to add some neuropathic medications. And then if this second step is not giving adequate pain relief, then you can stop tramadol and start strong opioids like that methadone, morphine, or fentanyl. Okay, again, that will not help for neuropathic pain. Then you can add, there also you have to add some that tricyclic antidepressants or anti-epileptic drugs for controlling neuropathic pain. And again, superficial pain. If the patient is having nociceptive pain, neuropathic pain, there might be like a superficial pain when we try to open the wound. Maybe when we touch the wound, the patients might have they tell like, I am having burning type of pricking type of wound. That may be because of the superficial pain, maybe because of the nerve injury. So that time your systemic analgesics may not help. Then you can think about local application, sensorcaine or lignocaine. Okay, so you can take 1 ml and add 3 ml of normal saline and the sprinkle that you can just pour that wound, and after 10 minutes, you can wait for it's around 5 to 10 minutes. That time the patient will get a local anesthetic effect. Then you can do the dressing. So coming to the malodor management, I already said these are the two causes. Anaerobic bacterial infection of the stale devitalized necrotic tissues in the wound. That is because of the anaerobic, that if the because due to that anaerobic bacterial infection there. So this is one of the cause of malodor, and the another one is tail exudate dressings. Coming into the management, empathetic and loving care, because malodor is one of the biggest problem. It will be affecting the patient as well as the family. Sometimes family members are not able to like maybe sit in front of the patient because of the malodor. So they are not able to living in that whole house because of the malodor. So this will be affecting the patient emotionally and spiritually because of my wound, because of my problems. They are not able to talk to me. They are not able to sit near to me. They are not able to living their house properly. So these kind of problems will be there. So we need an empathetic mind, and we need good maybe love heart to treat this kind of patient. This patient need a loving care. Again, I already said, provide a thorough bath before dressing, daily cleaning and dressings, use normal saline for cleaning, homemade saline, use absorbable dressings for removing exudate. The medical management is injection metronidazole irrigation. You can use same injection metronidazole for wash out, irrigate the wound. After that, you can use tab metronidazole, crushed it and make it a powdered form, and that powder you can apply on the wound. And then you think about systemic antibiotics also. Tab metronidazole, 400 milligram TAD. If the foul smell increase, then you can think about systemic antibiotics like metronidazole. Then the charcoal dressing. So this is one of the good agent for controlling bad smell. You can use charcoal dressings. The charcoal dressings are available, but the thing is very expensive. You can make charcoal in their in your home, or you can ask tell the patient to make charcoal pieces in their home, and that will help to absorb the bad smell. So these are the literature findings: sugar paste and medicated honey dressings. So this will suppress the bacterial formation, so that we can able to reduce the bacterial growth, and that leads to we can able to prevent malodor and burning flame. Also, if there is a malodor there, then you can use these type of things, committing or other orders, give some other like order these good smells, so that way we can able to that control malodor. And coming to the bleeding, always try to prevent bleeding. If they are bleeding there, you can apply the local pressure. If the bleeding is not controlled with your local pressure, then you can think about sucralfate powder. So sucralfate powder, which we are using for peptic ulcer management, that medication you can use for controlling bleeding. Take a tablet and crush it and make it a powdered form and apply on the bleeding point. And then you can use tranexamic acid. Then you can, if these measures fail, then you can think about systemic ethamsalate and palliative radiotherapy. Always you have to educate the patient about to keep some dark color clothes. That is very, very important, because if there is accidental bleeding happen, they have to take a dark color cloth like a green color or blue color cloth and wipe out the blood with the dark color cloth, so that we can able to prevent the anxiety. We can able to that prevent the panic shock. So these can sometimes, if you the wipe out the blood with a white color white color clothes, what happened? So that leads to bright red color, and others will think, oh, this much of that blood loss. So that create another problem. So better we can able to prevent that kind of problems for you using dark color clothes. And role of cancer therapies, the radiotherapy, cytotoxic chemotherapy, hormone therapy, and surgery. So if you do radiotherapy and cytotoxic chemotherapy and hormone therapy, this will help to strengthen the size of the tumor. Okay, it will not help to prevent cancer formation. This will help to strengthen the size of the tumor. That leads to we can able to prevent bleeding. Sometimes maybe the head and neck cancers, the huge growth there. Then if there is a chance to reduce the tumor size, then we can think about that. Before send the patient to the oncologist, you have to make sure that the patient's health status also. You have to think about that, whether the patient is able to underwent a chemotherapy or radiotherapy or something. So then only you have to decide to send the patient to the oncologist. And surgery, debulking surgery is also available, but the thing is the health status. If the patient is able to underwent this kind of surgery, then you can think about that. So coming to the maggots, so you all know that how does maggots come? Because due to the house flies. So always try to prevent maggots formation. Use mosquito nets, or they have to that cover the wound all the times. That way we can able to prevent maggot formation. If a person come to you with maggots, what you can do is you can use turpentine oil. You can soak the turpentine oil with gauze piece and keep close to the wound, so that that time the maggots will try to come out, because of the turpentine oil will reduce the oxygen supply. That time the maggots will try to get oxygen from the environment. So that time you can able to that take.
What did you eat?
Sister Anamal, could you please repeat the question? Maggot removal.
Yeah. So maggot removal, the physical removal is the only way for removing maggots. So when a patient comes to you with maggots, what you can do is you can take a turpentine oil. Some of the places they are using ether. We are using turpentine oil. That is the best agent for removing maggots. You can take the turpentine oil with gauze piece, and that gauze piece keep close to that area wound. No need to pour that wound directly. So that will create another problem, create irritation, especially head and neck cancers. They will not be able to breathe properly because of the turpentine oil smell. So better you can soak the turpentine oil with gauze piece and keep close to the wound, so that the maggots will try to come out, because they will not get adequate oxygen. Okay, they will not breathe properly, so that time they will try to come out. That time you can able to remove the maggots with the help of an artery forceps. Okay, and you don't follow maggots. Sometimes your artery forceps will rupture the blood vessels. When they come out, you can take it out. Thank you.
If there is no other questions, we can move on to our case presentation. Our case presentation is Sister Jia. Ma'am, over to you, ma'am.
Okay. Can you hear me?
Yes, you are.
Okay. I'm Jia Eun. I'm from Malaysia. I'm working in Pure Lotus Hospice of Compassion. That's one of the hospice with charitable in-service patient. So my case is a female patient, 88 years old, with diagnosis metastatic left breast carcinoma. When patient admitted to our ward with the presenting complaint is patient is weak and lethargic, breast lump size increasing, and she having left upper limb edema likely secondary to lymph node metastatic. So patient having loss of appetite, frequently low BP during dialysis, and in the private hospital, because patient is from private hospital, so the doctor, they already issued DIL for the patient, and patient require assistance for activity daily living. So the history of illness. Patient 2 years ago, when the doctor helped patient to shower, she detected a breast lump over the left breast. So they go and check and diagnose as cancer. So was counseled for surgery or chemotherapy, but the doctor not keen due to the patient age factor, and the doctor only want comfort care. And patient also having end-stage renal failure. So she's already on dialysis for 21 years. So every Monday and Thursday, the doctor will send patient to the dialysis. Patient also having rectal vagina fistula, which no treatment done, only conservative treatment. And then patient also having IHD, diabetic, hypertension, and dyslipidemia. During the examination in the hospital, patient done CT tap, show multiple left breast mass with infiltration and also bilateral lung nodules, so suggestive for the lung mets. So during patient admitted to our ward, patient is arousable but weak, poor appetite, having a left breast fungating wound with very big wound around 15 cm times 15 cm. So patient having left upper limb edema, having PV discharge which have light brownish color, and patient on dialysis with right AV fistula. Bowel pattern is normal, but patient already on dialysis for 21 years, so no more passing urine. And patient's skin was intact, no pressure ulcer. During last stage, when patient condition deteriorate, patient having frequent pain during the night, unable to swallow, complaint of shortness of breath and skin itchiness. So the treatment and significant investigation done is mainly is the daily dressing for the left breast fungating wound. The wound appear was dry and no exudate during the admission for like 3 days. But after 3 days, start having oozing and bleeding, and we needed daily dressing to cover the wound. So for the wound, we clean with normal saline. We apply the Bactigras to prevent the wound stick to the gauze, and Fajab powder, metronidazole, to reduce the false smelling from the wound. And also we apply tranexamic acid to stop the bleeding from the wound. So patient on dialysis, so she is restrict fluid 500 ml per day. So doctor will bring patient for dialysis 2 times per week. For the psychosocial aspect, patient is a widow, only have 1 daughter. Patient is Buddhist, but she always forgetful, even forget her own diagnosis. So far, patient never expressed regret or unfulfilled wish to the daughter. For the daughter side, daughter is single, is the main carer of the patient. She works as a promoter. That's her only income source. 50 years old. So she is a strong religious belief in Buddhism. The daughter experienced career exhaustion, depressed, frequent crying, don't know how to take care of the mother with the fungating wound become bigger. That's why she come to seek help from our hospice. Daughter also requests for end-of-life care patient in the hospice. So patient is on lots of medication. The first one is pantoprazole 40 mg daily, acetylsalicylic glycine, aspirin every alternate day, vitamin B complex 1 daily, CoQ10, this one is a supplement 1 daily, alpha calcidol 1 mcg daily. Because patient on patient is IHD, so she's on Wasteroid MR1 on morning, Panadol, paracetamol 1 gram BD, syrup Gaviscon 5 ml PRN. So during the last stage, our doctor add on the tablet Targin 5 over 2.5 mg on night, and subcut morphine 2.5 mg on night and PRN due to patient complaint of frequent night pain. So the main concern of the patient is fungating wound, need daily dressing, and she need assistance in activity daily living like sponging, changing the diapers, oral feeding, oral care. So patient having poor appetite, then we encourage them for small frequent amount of the diet. During the last stage, patient having pain, so we serve the Targin, subcut morphine when patient unable to swallow. So patient complain of shortness of breath, we started oxygen 2 liter via nasal prong. Patient complain of skin itchiness due to uremic because during last stage, patient unable to go for dialysis. And then we apply the lotion as a topical agent to reduce the itchiness. And when patient unable to swallow, we omit the oral medicine and ensure the oral care was done properly. So for summary, patient admitted on the March 20th, 2024 and expired on the 13th of March. So total stay in hospice is 25 days. Patient expired 2 days after the condition deteriorate. So daughter stay overnight with the patient to accompany her during her last stage. So daughter feel anxious and guilty during patient last stage when patient appear less responsive and not keen for dialysis. Counseling session was given by the doctor in charge. For the spiritual aspect, prayer and recite by daughter and social worker was given. And then we provide a peaceful environment for patient and daughter. And we help to lessen the burden of the daughter financially and physically. So the discussion point was when daughter expressed she feeling like she is killing the mother for stop sending her to dialysis. She wished to send her for dialysis, but patient condition was ill and not keen. So how do you respond as a nurse? The second question was patient complaint of shortness of breath. SpO2 check was 89% under room A. Daughter was anxious, requested to start oxygen. What should you do? Thank you.
Thank you, Gia, for brought out the wonderful patient story for today's presentation. Because I am sorry to hear that this patient is no more, but we need to discuss, because if you have seen these kind of patients later, then you have an idea how to take care of these patients. Your Gia is difficult to face these. Actually, she was difficult to that convey these kind of questions. So Gia is asking you, how will you manage these kind of problems? If you have seen these kind of patients and daughter is expressed these kind of questions to you, how will you respond? I hope this presentation is here to that clear to everyone. Now we all discuss together, and please put your thoughts in the chat box. The first question is, daughter expressed she felt like she is killing her mother for stop sending her to dialysis. She wished to send her for dialysis, but the patient condition was ill. The patient is not able to continue the dialysis because of the poor health condition. But again, the doctor is insisting you to give a dialysis. How will you respond as a nurse? That is the first question. How will you respond? Anybody?
Take time to understand the daughter and give counseling to her.
Okay.
She is only the caregiver, no other persons.
Okay, very good. We have to listen. So we have to understand her understanding about the disease, about her mother's disease. So we need to understand her insight first. For that, we have to listen. We have to sit down and listen her insight. Then,
I have little clarifications. This patient was admitted on 20th of March, and the patient died on the date may be missed. How long patient?
I think that is typing error is 4, I think.
Yeah. So how long the patient was in the hospice? That I would like to know.
I think 42 days, 20, 25 days. I think 23rd, 24 was admitted, and 4/24 was that time she died. So, Gia, is it correct?
Yeah,
20?
yeah. Sorry
Yeah.
for the typo.
Yeah. So
Yeah. So I just to express that the patient would have been, and a patient's the daughter would have been counseled the day of admission, and would have been cleared all her doubts and explained to her the condition of the mother. Then she may not have felt that the feeling, the guilt, she may not have felt it. We had explained to the patient and the family and the daughter.
yeah. So that is the another possibility. Always you have to, as we discussed earlier, we have to listen and understand her emotions, and then you have to educate her what she have understand about dialysis and what was the condition of the mother previous. So 2 months back, what was the condition, and now she needs to understand that level. Okay, from the 2 months back, she was little bit good that time. So after two months, she was deteriorated, right? So this is the not an in a good condition for giving dialysis. If you do dialysis, sometimes it will affect more, because that time she may not be able to tolerate the dialysis. These kind of things you have to tell her, so then she will understand. Otherwise, she won't be able to understand what is dialysis, what you are doing, that when you do the dialysis, how was doing that things. How was affecting her mother while be doing the dialysis. These all things will be important. So that is one important point. Any other persons would like to add any point? Here also I have seen many patients. So when a patient comes to you, come here with the father, or like we already learned about collusion. Okay. And they always try to hide the truth from the loved ones. That is called collusion. So what we can do is, sometimes they might be knowing, like when we try to break the that part, break the bad news. If you ask the patient about their diagnosis, they might be saying, usually they will say like, I know I am having cancer. If you ask them what is cancer, they don't know. They know they are having cancer, but they don't know what is cancer. So from that part, you have to tell them what is cancer. So then only they will understand about their seriousness of illness. So here also, I think the doctor need to give need a proper counseling and give a proper explanation about her mother diagnosis and treatment. Then she realized that okay, this is not a good time to continue the treatment. She should realize. So that thing you can do. You at least if you have seen these kind of patients later, then your first thing is you have duty to listen their problems and explore their insight about the diseases and treatment plan and all. So based on that, you can able to counsel them. And the second question is patient complaint of shortness of breath. Her SpO2 was 89%. Daughter was anxious, requested to start oxygen. What should you do? That is the next question. So very good question. Always we face these kind of questions. Always when a patient's in an end of life care situation, always the caregivers will tell you like you can give some oxygen. You can start oxygen. Now she is having breathlessness, give oxygen. So how will you manage? How will you overcome this situation? Anybody?
We again need an explanation to the family people.
Okay.
And then we can give for their satisfaction, I think we can give a low dose of oxygen.
Okay. Then any other answers?
And we can open the windows and give them fresh air.
Yeah.
Yeah. So
yeah,
that are
definitely non-pharmacological management always try it. You have to try all non-pharmacological management before moving to the medical management. So open the door, provide adequate ventilation, loosen the dressings, and these all things you can do it. And when usually the patients, the caregiver will request you to start oxygen. That time, what you can do is this is the common issue. What you can do is you can start oxygen with a minimal liter, and always you can use nasal prongs, not mask. Nasal prongs. If you use nasal mask, what that oxygen mask, what happen? If they want to say something, it will not. They will not be able to speak. Always you have to use nasal prongs. Try for only 10 minutes. After that, you have to ask the patient whether that oxygen is helpful or not. If the oxygen is helpful, then you can continue. Otherwise, you can take it out. So definitely you have to give oxygen, but not continuous. But after that, you have to ask the patient whether this is helpful or not. If that oxygen is helpful, then you can continue. Otherwise, you can take it out. Then the doctor will explain, okay, see, okay, she is also there, no? She will be able to observe, okay, that is not helpful, then you can tell her. So this is how we manage here when a patient comes to us with the breathlessness. They usually ask us to start oxygen. So then we will start oxygen with minimal 2 liter per hour. That kind of things we used to start, but we always use nasal prongs, and after that we will reassess. So most of the time the oxygen will not help. Then we will remove it. And also what you can do is be there all the times and give emotional support to her, and she is the only caregiver. She is the only one daughter. This is a huge problem for her because she is going to lost her mother. So this is the emotional and spiritual problems because we need to support her also, and needs to hear her emotions also. So if possible, so be there and support her and encourage the patient to sit there, encourage the caregiver to sit near to the patient and support her, and that kind of give some music if she is a that willing to listen music, encourage to hear some musics, these kind of things we can do. So always uh, we have to respect the patient emotions and respect the wishes, and at the same time we have to respect the caregiver's wish also. That we have to keep it in mind because of their loved one, because of their love and the compassion, they will try to that advise you, some give something, these kind of requests will be there because of that that love. So that we need to respect, and we have to respect their emotions and uh, educate them and convey the truth so that they can able to understand well. Okay, so if you don't have any questions, we can wind up.
Thank you, Sheeba ma'am, for the wonderful presentation. Thank you, Gia, for the wonderful case presentation. Thank you all for joining the sessions. Thank you. We'll see you in the next sessions. Bye.